come on camera and introduce themselves, and then we will dive into questions. Monica, why don't we start with you?
Thanks, David. Thank you all very much for having me. Monica Popp with Marshall and Popp, co-president of Marshall and Popp, a firm that I started with Hazen Marshall, who was Leader McConnell's policy director 7 years ago. So I've been downtown working on a variety of client interests, but in the healthcare space, primarily focusing on prescription drug policy. Prior to that, I was Senator Cornyn's chief of staff when he served as Senate whip, and then have had the pleasure of working both in the House and Senate before that over at the House Energy and Commerce Committee, which is really where I worked with David on many of the Medicaid issues, and have been able to also work at HHS. And I started my career working for Governor Jeb Bush here in DC, working on his Medicaid reform.
Thank you for making time to join us today, Monica, and it's always nice to see you. Edwin, please introduce yourself to the audience.
Sure. I'm Edwin Park. I'm a research professor with the Georgetown University Center for Children and Families. It's a research and policy center in the McCourt School of Public Policy that focuses on expanding coverage and access for children and families, particularly those with low incomes, with a particular focus on Medicaid and the Children's Health Insurance Program and the Affordable Care Act. Prior to joining CCF, I co-led the Center on Budget and Policy Priorities Health Policy team for many years, and also have worked at the National Economic Council in the Clinton administration, and also on the Senate Finance Committee as the Medicaid lead for Senator Moynihan. So glad to be here today.
Yeah, and thank you also for making time to join us, and it's good to see you. It's proof that it is a small town and the health policy world is a small world, but always nice to be reunited with friends, especially when those friends are smart and can help us make sense of things during today's conversation. So we tried to break things down in terms of thinking of questions to have discussions about today, and it seemed like thinking about different programs might be sort of the easiest way to do it. Given that we all share some past experience on Medicaid, I thought I would start there. And of course, this year was a big year for Medicaid back in July, although it feels like it was a long time ago, only about 5 months ago. Congress passed the budget reconciliation package, or OB3, the One Big Beautiful Bill Act, or HR1 if you prefer. And that really made, I think, the most significant reforms to the Medicaid program probably since the ACA, so about 15 years. A number of provisions, we don't have time to cover all of them, but highlights include new work or community engagement requirements, cost sharing on certain services for certain enrollees, more frequent eligibility redeterminations, a number of other changes on the financing side. And these all get sort of implemented on different timeframes. So it will be potentially a busy few years on the Medicaid front. But given the variety of changes that HR1 made to the program, I would love to hear each of your perspectives on what the collective impact on Medicaid beneficiaries will be. And Monica, maybe we can start with you.
Of course, yeah. I mean, I think in order to talk about some of the impacts, I think it's important just to spend 30 seconds from a Republican perspective, giving folks just an understanding on the kind of the theology and ideology that fed into some of the changes in here. When I go back and I look at the Medicaid spending over the last decade, frankly, back when I first started working at the committee, it has nearly doubled in spending as a program. That just shows you how substantial the program is, not just in terms of the federal budget, but state budgets as well. And I think that pressure and frankly continued interest from Republicans to look at the Medicaid program, not so much as a one-size-fits-all program, but a program that they believe to be a program of mandatory populations and populations that have expanded over time, obviously the ACA being a significant contributor to the growth of the program, but thinking through the program in different ways for different populations. And so many of the changes that you see, as you noted, not just to eligibility review and redeterminations, but also for work requirements, are not targeted at the entire Medicaid population, but really looking at, for example, the ACA expansion populations where individuals perceived to have the potential to seek work, the potential to study, the potential to see community engagement, can in fact do that. And obviously there are some requirements placed on those individuals. I would say, to answer your question, what are the most significant impacts on beneficiaries directly? Let's start with the work requirements, right? Day to day, that'll probably be the most significant change in the Medicaid program that beneficiaries in certain populations will face. And so I would say that's like the direct change to beneficiaries. Broader though, as you look at some of the financing changes on the provider taxes and how states are able to generate enough revenue to then draw down federal match, that certainly will have an impact on state budgets and the state's ability to generate revenue. The question now becomes, how do they find new financing mechanisms that are going to draw down additional revenue dollars so that they can draw down federal Medicaid match? The long-term question for the Medicaid beneficiary is this program something that needs to look and continue to look as the quote unquote Medicaid program, or are there opportunities in the future to think about reforms that allow people to maintain coverage, but where the benefit packages may change, where eligibility requirements may change? It's certainly not a bipartisan approach at this point, David, as you know, but I think over the long term, if folks were to kind of put partisanship aside, I think there's a logical way to approach the Medicaid program that protects the most vulnerable individuals and over the long term allows people not to stay on Medicaid if they don't need it, but that it's there for those who do need it.
Great. And Edwin, would love to hear your perspective.
Yeah, I think, looking at HR 1 and the impact on the Medicaid program, I think it's always important to take a step back and think about how this fits with sort of the broader coverage trends we've had over the past few decades, which is expanding coverage, increasing the number of people with health insurance. And so this will be, not only the largest Medicaid cuts in history, over $900 billion over 10 years, but the largest rollback in health coverage in history, according to the Congressional Budget Office, 10 million more uninsured by 2034. And 3/4 of that comes from the Medicaid and CHIP cuts, so 7.5 million. And if you look at the cuts in terms of the impact on beneficiaries, I think there's sort of two buckets. I think one is a significant increase in red tape to make it harder for eligible people to enroll and stay enrolled in the program. That's particularly targeted at the Medicaid expansion in terms of the work reporting requirements, in terms of people not being able to report work even though they are working or qualify for exemptions for which they should be eligible, more frequent renewals for those on the expansion, all of them taking effect January 1st, 2027. And we know from the Congressional Budget Office, as well as the experience with states with waivers during the first Trump administration of work requirements, is you don't see increases in employment or hours worked. You just see people who would otherwise be on the Medicaid program enrolled in the expansion being disenrolled. And so, that's going to be a large share. Just the more frequent renewals, the work reporting requirements is about 6 million of that 7.5 million. And I think the other bucket that Monica mentioned is a cost shift to states where the federal government is restricting how states are financing their share of the cost of the Medicaid program through provider taxes. No new increases in existing provider taxes, prohibition on some existing provider taxes called uniformity waiver taxes, and then restrictions on the size of provider taxes, but just in expansion states. And these provisions save money, they reduce federal spending because states will be unable to replace all of those lost revenues. And that's going to result in states having to make tough choices, including significant Medicaid cuts, eligibility, benefits, and provider payments, and not just for the expansion group, but throughout the Medicaid program. And that includes kids, seniors, and people with disabilities.
So, Monica, you started by sort of sharing the Republican perspective and a program where spending has increased significantly. Edwin's comments about the fiscal analysis clearly shows that states will be putting less money on the table to draw a federal match, and presumably that's true across the board, all states, maybe to varying degrees. But I wonder if you can talk a little bit about, assuming that sort of more bipartisan approach to revisit Medicaid is not going to happen in the next, say, 12 months before these provisions take effect. I wonder if you could talk a little bit about how, and tapping into your time, particularly with Senator Corden, a state that didn't expand Medicaid is sort of safe from some of these provisions because they won't apply, but not safe from others. And so how do you reconcile that fiscal pressure on state budgets, the choices that we know governors and state Medicaid directors are going to be faced with, and how does that facilitate or hinder that longer term potential coming together by Democrats and Republicans to revisit a program, in all fairness, right? That is 60 years old and has changed in a patchwork of changes over the last 6 decades.
Yeah, I mean, ultimately, I think the patchwork is what has made it really difficult to have bipartisan conversations about Medicaid, right? Because if you're kind of thinking of it as each party has put their stamp now on the program in different ways, for good or for bad. I think either side could choose to critique the other in terms of what they've done here. But for states that haven't expanded, certainly the financial pressures are there, especially in southern states that use provider taxes really aggressively. So how do they shift, not just from a financial perspective, David, but from a practical perspective, bringing in special legislative sessions, working with the legislature and the governors, and frankly, the stakeholders across the entire healthcare industry in states like Texas and Louisiana, Mississippi, and across, to figure out, okay, if provider taxes are limited, where can we go from here to ensure, to your point, that the mandatory populations are taken care of? I think that, when you sit back, regardless of your party, and you think about how the Medicaid program is structured, there are populations that, by the definition of how the program is structured, are protected because states must continue to cover. The question becomes, what about those optional benefits get cut? And I think we can all agree there are really critical optional benefits that are important to mandatory and optional populations that are important to the healthcare industry overall. So this isn't, I don't think about, when the Medicaid spending is reduced as it was in BBB, I don't think about this as like just a gubernatorial decision or a legislature decision. This is really a decision that has an impact across the entire provider community, across the beneficiary and advocacy community, and people have to kind of come together and figure out, where can we give and take here and build this out. The patchwork, though, at the federal level is what has made it more difficult for folks to come to a table and say, all right, this is kind of hanging on by threads in certain places and working in others. Where can we figure out, it doesn't, I think Republicans always like to say there was a Waxman approach to Medicaid growth, right? It was piece by piece. It's how Republicans see the growth. And maybe I think Democrats would see the BBB as a hammer, but a very dramatic cut. It wasn't piece by piece. But I think moving forward, we have to really start having conversations that are piece by piece, if we're going to keep this program on a sustainable path, for the long term. And I hope that, I think both parties would agree. This is a program that serves the most vulnerable Americans, and it needs to be around, and we need to figure out how to make sure it works for them first and foremost.
Yeah, Edwin, final thoughts on Medicaid before I move us to a different topic?
Yeah, I mean, I think it's always important to remember that states have to balance their budgets, unlike the federal government. And so, the changes to Medicaid financing through restrictions of provider taxes is going to put, states in a bind. They only have three choices. They can raise revenues, they can cut other parts of their budget, like K through 12 education, or they're going to have to cut their Medicaid programs. And the Medicaid cuts, the cost shifts in HR1 are happening in the context of other changes that shift costs to states, including SNAP, where states for the first time have to contribute as much as 15% of the cost of SNAP benefits. They're going to have to pay much more in terms of administrative costs. They're going to have to pick up 3/4 of all administrative costs over the next year. And then also the impact of so-called tax conformity, where the tax cuts in HR1, depending on how states have created their tax codes, can automatically result in revenue losses unless states so-called decouple. And so there's a lot of cost shifts putting pressure on states, and that's going to make it hard for them to mitigate some of these cuts in their budgets. But it does speak to the importance of revenues, that it can't be just a cuts only response to these cost shifts, that states are going to have to look at various revenue increases to try to mitigate some of these cuts. Otherwise, this is going to affect everyone on the Medicaid program. Again, not just the expansion individuals, but kids and families, seniors, people with disabilities, pregnant women, and others who've relied on the Medicaid program even before the Affordable Care Act.
Yeah, so definitely more to come. I think we could probably spend the whole hour talking about Medicaid, but I'm going to shift us over to the ACA marketplaces. HR1 made some changes to the rules around the ACA marketplaces. There were also some similar and some different provisions in rulemaking, a lot of talk about fraudulent enrollment, and how the advanced premium tax credits are used. This conversation, I wish I could say that we were prophetic and knew that convening at 1 o'clock on December 11th would mean that we could talk in real time about activity that literally is ongoing in the Senate around the enhanced advanced premium tax credits. But it turns out that was just good and coincidental timing. But the expiration of the enhanced tax credits has been widely reported as leading to very significant premium spikes, particularly for folks sort of in that 250 to 400% of poverty level. It has so far seemed to have suppressed enrollment during the open enrollment period. Edwin, I think we started with Monica on question one, so we'll start with you on this one. But I wonder if you could, talk about sort of market stability, and what, as there are changes in the individual market, what happens in other lines of business, right? Commercial or Medicare, Medicaid, other parts of the sort of insurance landscape. So I will let you talk about that.
Yeah, I mean, I think it's there's quite a bit of volatility, right? We have the expiration of the enhanced premium tax credits, which have directly contributed to doubling of enrollment in the marketplaces over the last few years since enactment of those enhanced subsidies in the American Rescue Plan Act. We have even bigger increases in the number of children enrolled in the marketplace. Children have been a relatively small share of marketplace enrollment, but enrollment went from about a steady state of 1 million to 2.6 million kids in the marketplace. And so you have the enhanced premium tax credits expiring and seeming likely to expire by the end of this month. You have marketplace changes that were included in HR1 that don't get as much attention, but account for about 2.4 million of that 10 million increase in the uninsured. And then you have the marketplace rules that were finalized by the Trump administration earlier this year that would likely reduce participation among those eligible for the marketplace and overall marketplace enrollment, some of which has been blocked by litigation. But that adds potentially as much as 5 million more uninsured if you have a full implementation of that rule and you have the expiration of those credits without any extension. And so that's going to be quite disruptive for not only marketplace enrollment, but also for the insurers that are participating in the marketplace. We saw that with all the premium filings even before HR1 was signed into law, that insurers were expecting not only reduced enrollment, but also changes in the risk pool as healthier people depart the market, as it becomes less affordable, more difficult to enroll. And I think that's only going to be more so just because of the uncertainty about whether there may or may not be some extension of the expiring premium tax credits. In terms of the spillover effects, I think there are a lot of them. I think one key aspect of the marketplace is that those leaving Medicaid whose income increases become eligible for the marketplace. If the marketplace is no longer affordable for those with low to moderate incomes who've now moved out of Medicaid eligibility range into the marketplace, that means that they're not going to be transitioning to a different form of coverage. They're likely going to be ending up uninsured. And so there's going to be effects about churn, particularly if, for example, they don't have coverage, they don't have their conditions treated, and then that may affect their ability to work. They end up going back on Medicaid, but they're in poor health, and when they increase their earnings and we're no longer eligible for Medicaid.
So Monica, I will let the audience know that right before we went live, we were chatting in the so-called green room, and you were kind enough to provide real-time updates on the vote. I don't know if you want to help folks understand what happened in the Senate, and then would love to hear your thoughts. And in particular, it is hard not to talk about the politics around Obamacare, and then of course the enhanced advanced premium tax credits happened in Democratic supported legislation during President Biden's term. Obviously now the politics are very different. So would love to hear sort of both the substantive response and then politically, given that my company and the rest of the industry that we're a part of are really very concerned about what will happen if and when these expire at the end of the year.
Yeah, I mean, I know, David, I think we can all acknowledge that both sides have used the budget reconciliation process pretty aggressively. And when you are faced as a party with whether to use it or not, in that moment, when it's your party, it's legislative malpractice to not attempt to use reconciliation, regardless of who's in charge. That moment and the leadership in that moment feels an enormous amount of pressure to do so. So, hindsight's always 20/20, and you can we have both used it. And I think what's difficult about reconciliation for all of us in DC, we can now, I think, conclude it, is that it is an imperfect legislative tool that ultimately causes both sides to ingrain themselves in their political base postures. And that's what makes it very, very hard to improve upon, to reform, to even have logical conversations about what to do next. And I think that's where we see ourselves right now, even though the EPTCs were ultimately enhanced, no pun intended, but enhanced in different legislation, also in reconciliation, outside of Obamacare. I think it's important for us to recognize that ACA was in 2010, and When you really look at the makeup of Congress and the makeup of both House and Senate GOP conferences, so many members have detached themselves from what I would describe as just sort of angry opposition to that particular political moment. And what you saw today, and I thought it was 3 Republicans, it was in fact 4 Republicans voted for the 3-year extension. What does that mean at the end of the day when you have a vote that's 51-48 for the Dems, 51-48 for the Republicans? There's bipartisan opposition for both, and there happens to be bipartisan support for one of the two. So now what? What do they do with that? Now that you have 4 Republicans voting for a straight extension, it's a reflection that there are obviously more members within the conference that would like to have a broader bipartisan conversation about either a transition period to something else or to other options for beneficiaries. HSAs would certainly be at the top of the list for Republicans, or it's just an acknowledgement that we have run out of time. And as much as members would like to have this conversation, leaving beneficiaries with no option at this point in time going into an election year is just not a sufficient response for a number of Senate Republicans. The question will be tested in the House later this week, and we'll figure out what happens there. And it's one of those moments when you work on the Hill, it doesn't matter how ideological you are, you start to recognize the politics of the moment. And the politics of the moment are, in fact, that members have heard from their constituents and obvious beneficiaries to you and to others on the phone who care about these credits. I think it has only escalated. And now when we are, 20 days away from the year end, members going home without a response has proven to be difficult. And so I expect conversations to continue. Whether or not there's a solution by the end of January, I'm just not sure, David. I think we can all sort of see with logical minds how you can get to a place where there would at least be an extension with some hope of having additional conversations. But the president will need to engage, and the president will need to have some, presence in the room and negotiating what comes out at the end of the month, at the end of next month.
Yeah, well, so we would love the I think it was a leaked document attributed to the White House that did have a 2-year extension. So I wouldn't be doing my job if I didn't say CareFirst would support that. We would also support the 3-year extension that did not pass in the Senate, but as you pointed out, did enjoy skewed, but at least bipartisan support, so that our members and people who would like to buy coverage on the individual market can get the help that they need to afford it. But definitely something that we will continue to watch. But one of the things that has happened given the uncertainty is that we've seen some states try to be proactive. And in our service area, Maryland may be the best example of that. They created, excuse me, a state subsidy program that would partially backfill some of the losses in the difference between the enhanced credits and the credits as they originally were included in the Affordable Care Act. Given the previous conversation that we had about Medicaid, and both of you identified, the pressure on state budgets, the looming Medicaid cuts and what that means, and needing time to plan. And I think I know the answer to this, but what is it that maybe insurers should be thinking about in terms of states cannot keep being a backstop financially, right? They just aren't in the position to do that. But I wonder if you have thoughts on what what the appropriate role of states is. What are the appropriate things for states to prioritize? What are the appropriate things for consumers in their role as constituents, for state elected officials, companies like mine that are also part of the community and want to contribute? How should we be thinking about all of the sort of pressure, cumulative pressure between these two markets, these two programs, on the states from both a financial but also a policy perspective. That's kind of a lot. Feel free to attack it in parts.
Yeah, I mean, I think going back to what I said earlier, sort of budget fights, just like budget fights at the federal level, but budget fights at the state level are sort of very wonky. It's about taxes and spending. Uh, but I think for everyone who has a stake in their health system at the state level, whether it's healthcare providers, insurers, of course, individuals and families who are relying on this health coverage, state policymakers, those, who care about education, care about childcare, other parts of state budgets. I mean, clearly, there has to be a significant engagement in state budget debates about spending and revenues, and that's going to be critical to preserve the Medicaid program to, if possible, backfill some of the changes to the marketplace, particularly if the enhanced subsidies do expire as scheduled. But I think it's critical to engage in these debates because the federal government, through HR 1, both the president and the congressional Republicans who passed it, many of these provisions are about shifting costs to states to try to divert at least some responsibility for some of the resulting cuts. But states, governors, legislatures are going to have to figure out how to respond, how to deal with the budget shortfalls that are inevitable. And I would just also raise there's a specter of potential downturn or recession, and states rely on these programs to help prop up their economies, both SNAP and Medicaid, and they're both being weakened in terms of their countercyclical role moving forward. So I think there's a lot to think about. There's also a lot to think about what states can do in the short term, particularly because states have very healthy reserve funds, so-called rainy day funds, but they're really available only for one-time expenses, and they can't offset the effects of these changes in HR 1, which are permanent. So it can potentially provide some way to mitigate these cuts over the next couple budget cycles, but it's not a long-term solution. So there's a lot to think about at the budget level. But for insurers and healthcare providers who may not usually engage in state budget fights, this is going to be absolutely critical, to ensure coverage and access is maintained as much as possible.
That's great. Thank you, Edwin. Monica, what do you think?
I mean, it's a terrible analogy, but I'm just going to say it because I can't think of a better one, David. States have ultimately become children in a nasty divorce. That's really what is happening here. And so, if nothing else, the role of states at the end of the day primarily has to be, dear federal government, either figure out how to work together on some solutions or give us much more authority to be able to build out our healthcare programs. Because what's happening here slowly is, I think a very long-standing stalemate, especially on healthcare between Republicans and Democrats, has proven very difficult for states of both parties. It is no secret that Republican governors were engaged during BBB. Even though they don't get loud on a microphone, it doesn't mean they don't still call, right? And so I think their continued advocacy is really important, not just for sort of the health of politics generally, but also because as a healthcare industry, we have become less popular with the base voters on both sides of the aisle. And so we are not always our best advocates, candidly. We explain our issues well. We can give you kind of the data points of what something means. But from a political perspective, legislators, governors still continue to have a very substantial political role in making sure that Congress acts one way or the other. And I candidly think the fact that we had a 51-48 vote both ways shows you that state advocacy continues to be an issue.
Yeah, and things from, I think, from the state perspective, right? Never really go away and never get better, right? So it's sort of that idea of something festering and budget. I think the state budgets are a great example of that. I want to shift to talk about prescription drugs. In my experience, I think we have seen some really interesting and unique approaches by President Trump and his administration. The multiple agreements that he has reached with individual drug manufacturers are things for which there are no real corollaries out there. I think there are still a lot of questions about what they will mean in terms of dollars and cents, access, utilization, maybe some different things for different markets or lines of business, right? Medicaid has often been called out in those agreements, and we know that Medicaid has a different approach on prescription drugs than Medicare, right, which does some drug price negotiation. Those announcements were also just released for the second set of drugs. Of course, that was a program launched by Democrats, but one that the Trump administration appears to have embraced. There are also all the sort of perennial issues, as I would call them, because they've been floating for a very long time, including when all three of us were up on the Hill. Those sort of whole patent bundle of issues. What is the right, exclusivity policy? Can we bring biosimilars to the market more quickly because of the promise of lower costs that they represent? We also see really significant differences in spending on prescription drugs by what my company would call business line, right? But even from the federal perspective, Medicare spends a lot of money on prescription drugs, and maybe more than the percentage of people that it covers. Certainly, if you compare Medicare and the commercial market, which is a little bit unfair given that Medicare skews older people tend to take more drugs, but Medicare is funded out of taxpayer dollars and trust funds, so there are long-term sustainability questions there. On the employer side, there's the whole affordability. Can we continue to afford this coverage? So a lot of very interesting things happening. I think I read even now that Florida is considering adopting something modeled on this most favored nation concept that President Trump has been successful with. So really a whole mess of issues there, but would love to spend most of the remaining time together talking about that, because it is really among the top drivers of the cost of insurance. And we continue from an insurer perspective to support multiple policies that we would hope would bring down the cost of drugs, but so far a lot of those things have been more about promise than about realistic savings. So Monica, happy to start with you, and then we'll bring you in, Edwin.
Yeah, I mean, David, it wouldn't be a call if we didn't totally have one moment where I disagree with you, which is the thing that really I struggle with when we talk about prescription drug spending is that, unlike other sectors, prescription drugs get wrapped in as like one tagline: prescription drugs spend. And at the end of the day, when you really separate it out and you think about preventive care, acute care, if you think about prescription drugs and you think about the spend, it really becomes isolated to a small subset of drugs that are quite expensive. And we can have all sorts of hours and hours of conversations about why that is. And we could probably all point fingers at each other, right? But I think what's really important about what's happening right now is this administration, to your point, has decided to use private agreements and private negotiations with the big 17 pharmaceutical companies on the planet to figure out how to equalize out-of-pocket pricing. Not just out-of-pocket pricing, but pricing for the Medicare and Medicaid programs. But to some extent, they're also thinking about how to get into the commercial market. And I think that's where I want to say the question will really be tested. The first test will now be in Q1 as Trump RX launches. And what does that look like for patients? And how do the out-of-pocket exposures interact with where beneficiaries expect them to be? So from a political perspective, I think we'll start to get some analysis in the first 2 quarters of next year about what some of these agreements could actually mean for the beneficiary. But long term, what I find really interesting, and I also think it's already kicking in, is that what we're starting to see is ex-US countries and ex-US negotiations are already changing. We are starting to see the increased advocacy of foreign governments on Capitol Hill talking about what MFN could mean for their spend. They are worried about this particular policy because they realize they may actually have to pay more for innovation. That is probably a good thing from the industry's perspective. I think it's a fundamental question of what does it actually mean for access over time? And I think, Europe will have to struggle with that question. The US will ultimately have to struggle with that question over time as spending goes up. But that is sort of at the core of this issue is what are we willing to pay for and when in the process. But I think these conversations have been healthy. I frankly, maybe just my Republican ideology, I'm happy that they're private negotiations, that companies are coming forward and negotiating these terms. They're confidential for as long as they're confidential. That as oversight kicks in, these agreements will certainly come to light. But to me, they are better than a mandatory regulatory pathway or a mandatory legislative pathway, when in fact, this is an opportunity, again, for folks to come to the table and figure out, all right, well, this thesis that the US pays more than other countries, true. Why is that? We invest more in research. Okay, fine. Is that fair? And the question of, is it fair? I think we can now all conclude it's not fair. And so if it begins to answer that question and move the ball forward in a way that allows Americans to have more access, I think that's a good thing. All the reasons that go into drug spend, though, is a call in and of itself, I think.
Yeah, I'm sure that's right. Edwin, how about you?
Yeah, I mean, I think, going back to our discussion of HR1 and the Medicaid cuts, prescription drug spending is about 10% of Medicaid costs, but states are very, very concerned about recent cost increases in the prescription drug area, particularly with some of the cell and gene therapies that have 7-figure price tags and likely will have 8-figure price tags in the foreseeable future, and whether they're able to absorb those costs, particularly with all the state fiscal pressures they're going to be facing in coming years. And so they are I think interested in this generous model, which is what the Center for Medicare and Medicaid Innovation announced as implementing some of these pricing agreements with certain drug manufacturers. But of course, there's a lot of questions of whether this would actually produce any meaningful savings for states, including how large are these discounts going to be compared to some of the existing discounts that are required in the Medicaid rebate program, supplemental rebates negotiated by states, as well as questions about what manufacturers have to do if they agree to participate. Can they choose what drugs are subject to MFN pricing like states can? And so, it will be interesting to watch as this model moves forward, how much interest it generates from states and whether states participate to a great degree and whether more manufacturers participate. I think one thing to look at is how another model that's much farther along in the process related to the federal government negotiating supplemental rebates from manufacturers for 2 gene therapies related to sickle cell disease, how that compares, what the results are compared to what states are able to negotiate on their own. So I think there's going to be a lot of interest on the part of states in moving forward and innovating more on prescription drug cost containment measures. I think the one thing to be concerned about, particularly from a beneficiary perspective, is whether states in light of these pressures, try to move to just stop covering certain high-cost drugs. Right now, Medicaid is an open formulary protection, but in the first Trump administration, there were states like Tennessee that were trying to impose a more closed formulary. And the example of what that could mean for individuals who rely on Medicaid, you can look at what happened in Puerto Rico. They weren't part of the Medicaid rebate program until recently. They did not cover any hepatitis C curative therapies until 2020, even though those drugs first came to the market in 2014. So I think that's something to watch for that could affect access to some of these, breakthrough first-in-class therapies that are coming to the market, particularly in the cell and gene therapy space.
And so if there was one thing that each of you could do in the drug policy space to sort of maintain innovation, but address the affordability / financial piece, what would that be?
Without a doubt, 340B reform would be at the top of my list. I think it is time for us to figure out how to either get that discount direct to the patient or restructure the program entirely. But the growth of the 340B program is just simply unsustainable. And frankly, at the end of the day, it's contributing to spend across the board that is really just lacking some transparency.
Yeah, I think, again, speaking just on Medicaid, what more can be done to build on the existing drug rebate program, particularly for certain types of drugs, at least initially, that can have such a big price tag, potentially have a disproportionate effect in terms of the makeup of the Medicaid beneficiary population in terms of who might most need certain types of drugs, helping states maintain that coverage, that open formulary, while ensuring access. I think is something that has been talked about. Discussions in the Medicaid Chip Payment and Access Commission (MACPAC) in the past is what can be done to ensure that the lowest income Americans who rely on Medicaid have access to some of these therapies that may be true breakthroughs, curative therapies, and that they don't face a two-tier system as a result.
All right, well, we'll have to pause on the drug conversation there. Maybe we'll pick that up at another time. But we have just several minutes left, and I thought it might be nice to try to end on a positive note. So would love to ask both of you, what's something that you're optimistic or hopeful about for health policy in 2026? And I think this time it's your turn to start, Edwin.
Yeah, from my perspective, I think looking ahead to 2026, Medicaid and the Affordable Care Act have never been more popular. I think that that was really crystallized in 2017 in the failed effort to repeal and replace the Affordable Care Act, but also with the cuts to the Medicaid and the marketplaces in HR1, and also the debate over extending the expiring enhanced premium tax credits. It's clear across party lines there's strong public support for these public programs, and they're certainly a critical element in the healthcare system, both nationally but also in individual communities, particularly rural communities. And that really came to the fore. Obviously, I would not prefer not to have the healthcare cuts in HR1 enacted into law, but it's clear that the debate over those cuts, as well as the ongoing debate over the expiring ACA subsidies, those programs, the role they play, the connection that families have to those programs has really been highlighted in this debate. And to me, that's hopeful for those programs moving forward.
Yeah, and before I turn to you, Monica, I would add, and I think probably all three of us would agree. I I think one of the fundamental problems that Medicaid faces is that people don't understand how it works, mostly because it really doesn't work in a single way, right? That the old saying that if you've seen one Medicaid program, you've seen one Medicaid program out of the 55 between the states and the territories. And, as I paid attention to what was happening this summer or the spring and summer, it did force people to better understand that Medicaid is actually the most complex healthcare program we have, because it's really 55 programs. And Monica, you mentioned earlier, right? Even just the use of provider taxes varies by states, and all of that. If I was being optimistic, which is not natural for me, as we all know, an increased understanding hopefully puts that program in a better position, and at the right time, right? With all of these changes coming down the pike, and tough decisions to be made, I'm hopeful that people tend to be afraid of things that they don't understand. So hopefully we've gotten beyond that. But sorry to interject, Monica, would love to hear your answer.
No, we didn't mention it when we were talking about Medicaid, but the Rural Health Transformation Fund from BBB, I know that it will be critiqued for not being enough money and the size and scope and whatnot, but there is an element of it that I am kind of excited about, which is it may be testing its name in purity of rural health, but to the extent that those dollars are used for innovation and they're used for expanded technology, which can improve access for individuals across the state, rural, urban, especially the most vulnerable in those communities. I think that's an exciting thing to watch, in my opinion, and to see how states will use those funds. I think it's really easy for us all to look at applications and quickly critique based on our own self-interests. But to the extent that those funds are being used to test new ideas, I think that's really exciting. And the last thing I'd say is, look, I'm really new to AI, and I'm probably like so many or so few of you, actually, I should say, who's like reading books on AI and trying to even understand how any of this works. I'm new to even using AI at work. But I'm excited to see where this is going. I think there's a lot of really cool things going on in behavioral health, a lot in conversational AI, and some of this technology is really far along and the private sector is running with it. And I think that's an exciting thing that CMS is doing. So I'm pumped about that. And the last thing I would say is, America is still an innovative place, and there's a lot going on in the oncology space and the Alzheimer's space. So for patients and families across the country, I think that there's a hopeful message coming for so many disease spaces. And so that also excites me. And I know for everybody on the phone, it's like, it means money, but in the moment, it's just like human beings. I think we can continue to celebrate continued American innovation. So that's where I'll end.
Yeah, no, that's a great list. And it's nice that we could all come up with something to be optimistic about. We are pretty much at time, so I'm just gonna thank both of you for your time, for being smart, for being thoughtful, for joining us. Really do appreciate it. I hope that the folks in the audience have heard and learned a little bit more about the implications of some things that have happened in 2025, some challenges for policymakers that lie ahead. Excuse me, certainly some work that lies ahead for companies like mine and other stakeholders in the healthcare sector. And really, on behalf of CareFirst, thank you everybody for joining. Thank you, Monica and Edwin. And we look forward to seeing you next year. And until then, take care and have a great day. Thank you.
Thank you.
Thank you.